Sufentanil citrate, or Sufenta, is supplied in 50 microgram per milliliter vials. The mechanism of action of sufentanil citrate is a fast-acting phenylpiperidine opioid that activates G proteins, specifically GI proteins, which cause enzyme regulation and ion channel regulation. More specifically, when sufentanil binds to a mu receptor in the presynaptic and postsynaptic membranes, which are GI proteins, it inhibits the activity of adenylyl cyclase and its conversion to cyclic AMP. Electrophysiologically, after it binds to the mu receptor, the inward rectifying potassium channels are activated and the voltage-gated calcium channel is inhibited, leading to hyperpolarization. At the level of the spinal cord, a high density of mu receptors have been identified within the dorsal horn. Sufentanil's actions within the central nervous system are mainly in the locus coeruleus and the periaqueductal gray area. The binding of sufentanil in the CNS activates the descending inhibitory pathways that cause the release of the inhibitory neurotransmitter serotonin, or 5-HT. The serotonin then travels to the dorsal horn of the spinal cord, which is additive to the direct action produced there by the sufentanil. Sufentanil is highly potent and only requires minimal receptor occupancy for a maximal response. The dosing of sufentanil is most frequently administered intravenously, but can be administered in conjunction with neuraxial anesthesia to amplify its analgesic effects. The loading dose of sufentanil IV is 0.01 to 0.05 micrograms per kilogram, with a maintenance dose IV of 0.01 to 0.04 micrograms per kilogram per minute. When used in conjunction with a neuraxial anesthesia or in an epidural, you can use 10 to 15 micrograms with 10 milliliters of bupivacaine at 0.125%. And remember, sufentanil is 10 times more potent than fentanyl and 1,000 times more potent than morphine, so use with caution. The onset of Sufenta is 1 to 3 minutes IV. The peak is 3 to 5 minutes, again, when you use it IV. The duration of action of Sufenta is 20 to 45 minutes, with clinical effects ranging from 30 to 60 minutes. The highly lipophilic, or lipid-soluble, properties of sufentanil results in an increased crossing of the blood-brain barrier and contributes to the rapid onset time of 1 to 3 minutes. The T1/2 alpha, or distribution in the body, or called the plasma half-life, is 1 to 2 minutes, and the T1/2 beta, or when half of it is eliminated from the body, is about 2 to 9 hours. The liver, or hepatically eliminated metabolism, specifically by the CYP3A4 and CYP3A5 enzymes, the small intestines, and the pulmonary system are the major sites of excretion from the body. The lungs exert a significant first-pass effect and transiently take up approximately 75% of the injected dose of sufentanil. 80% of sufentanil is excreted within 24 hours, and about 2% is excreted unchanged in the urine. Sufentanil is approximately 93% protein bound and can also be reversed by naloxone, or commonly called Narcan. So make sure you have that on hand as well. The anesthetic indications of sufentanil is indicated for IV administration as an analgesic adjunct in the maintenance of balanced general anesthesia in patients who are intubated and ventilated. It is also indicated as the primary, but not the exclusive, anesthetic agent for the induction and maintenance of anesthesia with 100% oxygen in patients undergoing major surgical procedures, such as cardiovascular surgery or neurosurgical procedures in the sitting position. Sufentanil is also indicated to provide favorable myocardial and cerebral oxygen balance, or when extended post-operative ventilation is anticipated. The anesthetic contraindications and concerns with sufentanil is that it causes significant respiratory depression that can be enhanced when used in combination with other sedative-producing drugs, like benzodiazepines, potent inhaled anesthetics, barbiturates, and our old friend alcohol. Sufentanil has a propensity to increase tidal volume while decreasing the rate and overall minute volume. The most common cause of morbidity and mortality with sufentanil is almost always related to its respiratory depression effects. Like other synthetic opioids, sufentanil, in large doses, can lead to chest skeletal muscle rigidity, or mahogany chest, which can increase your airway resistance and further complicate your respiratory management. The incidence and severity of muscle rigidity is dose-related and may occur with agents that have a rapid onset of action. An additional concern with the administration of sufentanil is the relaxation of the lower esophageal sphincter tone, especially in those patients with a history of gastroesophageal reflux disease, a full stomach, and those requiring rapid sequence inductions. Sufentanil may increase the risk of regurgitation and aspiration. Sufentanil also has a propensity to cause marked hypotension, especially in the presence of endogenous catecholamines, and caution should be used with the elderly, especially when they are hypovolemic. And in the gravid mother, you can have fetal respiratory compromise if you use sufentanil. Here are some links that will be helpful to provide some background information on sufentanil, and here are the references that I used throughout my presentation. And of course, I am open for your questions at this time. If you have any, please fire away.